virtual questions.
تبدأ في ناس أونلاين. راح نبدأ خلال 45 أو نخلص 55. ما نقدرش نتأخر.
خلاص تمام حكي خلاص إن شاء
الأسئلة بتجيك على الإيباد.
يعني ماكسيموم 2 اور.
الله. لا
لا.
1 hour and a half.
لا مش ساعة و50 دقيقة.
ساعة 50.
و5 ورق 30 دقيقة 50 دقيقة طيب احنا مش رايحين مش رايحين نتذاكر.
الويب سايت مكتوب 1 اور 30 minutes.
مدينة إن شاء الله.
اوكي.
على كل حال يعني أكيد مش رايحين.
We have plenty of time.
Okay.
We can enjoy the discussions.
Yeah, definitely. So we will then start on time إن شاء الله.
Yep.
بس نخلي تليفونك على silent.
أيوة صح. يعني I think we can take our seats and we have to start on time and it's very short.
Oh, sure.
Yeah, thank you.
ساعة ونص. هذا نعم. اللي عارفينه. شغالة بدون الزرار ولا؟
Yeah, it's automatic. He will be muting us. Yeah.
Thank you for coming. There are other people online, so don't worry.
Shall we start? Yeah. Good afternoon, distinguished guests, fellow researchers and attendees. Today we gather for a panel discussion on the bioethical dimensions of COVID-19 vaccination. This discussion aims to explore the intricate ethical considerations that have been the subject of intense debate during the unprecedented global efforts to vaccinate millions and millions of people against COVID-19. We will have also special focus on the experiences and strategies implemented here in Qatar. As we delve into these issues, we will have a panel of distinguished experts who will provide their insights based on their professional experiences and as well as their research as leaders of Qatar's national COVID-19 national response. I am Laith Abu Raddad. I'm an infectious disease epidemiology at Weill Cornell Medicine here in Qatar. I have no conflicts of interest to disclose, nor any of the panelists. So before we start, we'll just try to give some context for this discussion. Sorry, I need to introduce the panel discussant first. So we have here distinguished panelists, starting with Dr. Abdulatif Al-Khal, who is right here, who is head of infectious diseases at Hamad Medical Corporation, who has been the chair of the National Health Strategic Group on the response to COVID-19. So he was in charge of the whole response in the country. And he was the previous chair of the National Immunization Committee. We have also with us Dr. Hanan Abdel Rahim, who is Professor of Public Health and the Dean of the College of Health Sciences at Qatar University. She has been a member of the Scientific Research and Reference Group, SRRT, which is providing the scientific input for the national response. And she chaired the Epidemiological Surveillance Working Group as part of this SRRT. Last but not least, we have Dr. Hiyam Shmaitilli, who is Assistant Professor of Infectious Disease Epidemiology at Weill Cornell Medicine and an expert in conducting vaccine effectiveness studies with a focus on respiratory tract infections. So as we start, just to provide some context, vaccination is the most successful medical intervention in human history. Simply, and this is just a scientific fact, there is no intervention that comes close to how beneficial in terms of enhancing public health as vaccination. It is thanks to vaccination, life expectancy, largely to vaccination, life expectancies globally increase threefold within 100 years, something the first time to happen in human history. This is here life expectancy in the US, where you see this threefold increase within 100 years. And why such a very rapid change in life expectancy within only relatively short time? It's because of avoidance of early death. Historically, half of children used to die before they reach their 5th year of age because of childhood diseases. We have now vaccines for all of these childhood diseases. So these kind of early death, premature deaths are almost now gone. Here is the survival curve in the US. Tells us what proportion of the population survive as a function of their age. And as you can see, the vast majority of the population can actually hope and plan to live long life and to reach retirement and even enjoy many years in retirement. This is largely to vaccination. So one would think if this is really the most effective medical intervention in human history. This should be the least debated, in fact, as a result. Well, unfortunately, this is not the case. As you have all seen, there has been over the last 2 to 3 decades beginning of debate about ethical dilemmas in relation to vaccination, which became quite intense during the COVID-19 pandemic. And this is why we are here today, in fact, to have this discussion. And it's important here to highlight that this debate is really not an academic, luxury. This debate has, in fact, consequences. This is, in fact, one consequence of it. This child is a Pakistani child. He did not have the opportunity to get polio vaccine unfortunately, because of misinformation. And as a result, he has to live with polio paralysis for the rest of his life. So this child is already growing in a very poor country, in a poor neighborhood. He's having lots of hardship in his life. And now a huge amount of hardship has been added to him simply because he did not take one small drop of liquid put in his mouth. How simple is this intervention? Unlike this other child who is actually lucky enough to receive this very small liquid in the mouth and to be protected for the rest of her life. So these are really the implications of these ethical dilemmas that we are discussing today. So now I will pass it to Dr. Abdul Latif Al-Khal, who will provide an overview about Qatar's national strategy in relation to COVID-19 vaccination. So the floor is yours, Dr. Abdul Latif. And can we have the slides, please? Second set. Thank you.
Thank you. And can you move to the next slide, please? Thank you. Yeah, thank you. So thank you, Dr. Laith, for the kind introduction and for setting the scene. Here in Qatar, very early on in the pandemic, as manufacturers of vaccines were working on potential candidates for vaccines, we very proactively approached the major manufacturers. So we approached Pfizer, Moderna, and Moderna at that time did not have any vaccine that was licensed. We approached AstraZeneca and Johnson & Johnson. We actually had the option to use some of the vaccines that were used in other GCC countries that was manufactured in China, but we elected not to go for it because it was not tested and we didn't think that was very ethical. So we were preparing very early on to receive the vaccine, hoping that we would receive it by the end of 2020. And in preparation, what we did is we created a COVID-19 vaccination task force, and we broke it into 2 groups. One of them, the first one, is called the Vaccine Allocation Task Group. The main role of this task group is to oversee the appropriate and rational execution of the approved COVID-19 vaccine allocation strategy, which I will share with you in the third and last slide. And the vaccine advocacy group that was leading on advocacy campaigns and communicate and sending reassuring messages to the public about the vaccine. Can I have the next slide, please? So this all started very early on, well before the end of 2020, and then in the second half of 2020, when we received the very first shipments of the vaccine, we had implemented the strategy which we planned very early on. And because we knew that we will not have enough vaccines for everyone, we had to prioritize, and we came up with this strategy that's based on another framework. And we modified it, and we prioritized it, broke it into 4 phases depending, on the availability of the vaccines. So as you can see, for example, in the first phase, we gave absolute priority for 2 main groups: those who are at greatest risk for severe COVID-19 or death from COVID-19, and those who were not at risk for severe COVID-19, but they were very important and vital for the continuity of essential business in the country, like healthcare workers or civil defense and so on. So these were the major criteria that we used initially, and then as vaccines became available, we started moving from one phase to the next, depending on vaccines availability. This way we ensured equal and fair and equitable access for everyone who need the vaccine, regardless of their nationality, gender, ethnicity, background, their belief, and so on. So this way, we think that in Qatar we were as ethical when it comes to justice in distributing and accessing the vaccine as we could. So I'll stop at this. Thank you.
Thank you very much, Dr. Abdul Latif. So now I will pass it to Dr. Hiam, who will be just giving us a very quick overview also about the kind of vaccine effectiveness that we have seen here in Qatar. Please, next slide, please. Thank you.
Thank you, Dr. Laith, for the kind introduction. So I will talk to you about COVID-19 vaccine protection based on what we found in Qatar, which also aligns with the global evidence. So I will do so by answering a series of questions. And the first question is, are vaccines effective in preventing severe forms of COVID-19? And the answer is yes. We have been following people for over 3 years, and what we found is that vaccinated individuals reduced their risk of getting severe COVID-19 or fatal COVID-19 by 96% compared to individuals who remain unvaccinated. This brings us to another question. Are vaccines effective in preventing infection with COVID-19? And the answer again is yes. Vaccines induce protection against infection. However, this protection is short-lived and people typically lose their protection within a year. However, just to stress that even though individuals lose their protection against infection, the protection that they gain from vaccination against severe COVID-19 or fatal COVID-19 is robust and is strong and long-lasting. So based on this, do we really need vaccine boosters? And the answer again is yes. What we found is that boosters, they restore the lost protection against infection. So even though this protection will eventually wane, and we will need to continually boost individuals, however, getting a booster will restore this protection against infection for individuals who get the booster. And very importantly, what we found is that boosters, they even enhance the protection against severe and fatal COVID-19. So people get an additional protection on top of the protection provided by only 2 doses. And this is especially important for individuals who have weak immune systems, like older adults or people who are immunocompromised or who have multiple comorbidities. These people really should consider taking their boosters just to keep themselves protected from the infection and its sequelae. So another question is, do vaccines have side effects or cause adverse events? Well, yes, adverse events have been documented among vaccinated. However, typically, they are mild and rare. And most reported side effects are easily managed and treated. Really, the likelihood of a serious side effect caused by vaccination is extremely low, and it is way lower than the risk of getting severe COVID-19 or of developing long COVID for people who remain unvaccinated. And although there has been lots of discussion, particularly in social media, about vaccination causing all kinds of side effects like infertility and DNA alteration, really there has been up-to-date no evidence or scientific support to any of these claims. So to summarize, really, the value of COVID-19 vaccines is indisputable. They have saved millions of lives, and they have saved many individuals from getting severe illnesses. And although side effects exist, they are rare and they are easily manageable and treatable. And serious side effects are extremely rare. Thank you very much.
Thank you. Yeah, thank you very much, Dr. Hiam, Dr. Abdulatif, for setting the stage for this discussion. So now we will move to this discussion with the panelists. And I will start with Dr. Abdulatif Al-Khal. So basically, the strategy in Qatar was to have equal access for everyone to the vaccine, regardless of any other considerations. However, some people were still more equal than others in terms of their priority to get the vaccine. Is it really ethical that we actually distinguish some people as opposed to others that they could take the vaccine before them?
Yes. And I think maybe I partially answered the question in the slides that I presented. But during the last few months of 2020 and just before receiving the first very valuable and the very much anticipated deliveries of COVID-19 vaccines, the hottest topic of the moment was who should, and this is not only in Qatar, but worldwide, who should receive the very first shipments of the vaccine. Here in Qatar, like in many countries, we were very careful and very intentional in ensuring fair and equitable access to the vaccine for those who needed it most, and making them a priority regardless, again, of their nationality, their ethnicity, their gender, or their socioeconomic status. So whether they are citizens or not citizens, whether they are laborers or blue-collar workers or white-collar workers, they had equal access to the vaccine if they meet the eligibility criteria. The main criteria, again, was age or chronic diseases or both, and the important role that they play in providing community services like healthcare professionals and civil defense again. Ultimately, our goal was to give the vaccine for everyone, every single person in the country, as approved by the regulatory authorities, whether the FDA or EMA or other authorities. And we identified the most vulnerable population through the unified health record system. So we knew patients based on their age. So we started, for example, with those who are 70 and above, and then we moved to those who are 50 and above. We reached out to all those who had immunocompromising conditions, like all the transplant patients, all the cancer patients, all those with renal failure, all those with heart conditions, because we were lucky as a country. We had one unified electronic medical records where we could reach all those patients. So through using this approach of prioritization of the population based on the level and the level of risk of severe disease or death from COVID, regardless of their background, reflects, I think, justice in accessing the vaccine, ensuring equality and avoiding disparities. And from my point of view, this was highly ethical.
Yeah, so it's very interesting. So it's really the concept of justice and fairness here, which really brings the ethics, which sometimes compels us to give the vaccine fair to some people as opposed to others. But this is still consistent with the basic underlying ethical principle. So now coming to a question actually related to this, but from a different angle, to Dr. Hanan. So for COVID-19 vaccines, we saw a situation where powerful, rich countries, actually including Qatar, got the vaccine first before actually other, and they got the better vaccines. So we have been using really the world's best vaccines here, which also Dr. Abdulatif alluded to, that we really focus on getting the vaccine that had the best evidence in terms of effectiveness. But this actually inherently there is an inequity here. And this inequity does not only is only for vaccination. We see inequity in a lot of things, across countries globally. Is this actually ethical? And what we can do about it?
So thank you, first of all, for the question and for convening this panel. And I'm very happy that throughout this conference, there is a track that's dedicated to public health ethics, because that's quite distinct from healthcare ethical issues. And, you know, vaccination might be one of those lightning rod issues that kind of demonstrate that. So the question of, you know, is this unequal access or inequitable access actually ethical? Where as someone in public health, where the underlying principle is that we reject unfair disparities, no, that's not ethical. And that applies not just to vaccines, but to many other resources that people need to be in good health. So the idea that two people with identical conditions can end up having very, very different outcomes in terms of survival and quality of life and so forth because of geography, because of where they live, the country that they were born in, you know, is definitely counter to the values of public health. Now, we know that these questions also in reality are very difficult to implement. So what Dr. Abdul-Latif, for example, described was a framework that you know has been applied to try to decide how we can allocate scarce resources. And again, that's what public health is all about. That's what it deals with all the time. There are never unlimited resources. You will always have to make choices. How can you make ethical choices? And one of the ways is exactly that framework that was described. And it starts with, well, we agree on what core values we share and that are important to us, right? Fairness being one, justice being one, minimizing harm and maximizing benefit, mitigating inequities, for example, and existing disadvantages. All of those, I think, are core values that we should discuss, maybe not at the height of a pandemic, you know, something that we need to be discussing throughout. And then based on that, you create those priority groups like, you know, the healthcare workers that we needed for the continuity of services, like the elderly or people with comorbid conditions and so on. And then there's the question of how you apply it. And we know that there can be many hiccups along the way, so that the implementation, despite the best intentions, may not really in the end align with those values. So it's difficult. And I think right now what's a little bit disheartening for me in terms of, you know, this is happening in country, in terms of the global picture, what is that, you know, we had hoped that there would be a pandemic treaty signed by the end of the World Health Assembly, and that didn't happen. The good news is that there's supposed to be, you know, a time limit for how long it's going to take to negotiate it, but I think the fact that it couldn't be concluded as hoped at the WHO is because of these very, very difficult and contentious issues, unsurprisingly, between the rich and the less rich about, you know, intellectual property and sharing resources and access and so on. So, you know, nevertheless, that's to be expected. These are in reality very, very difficult issues, but, you know, it is my sincere hope that you know, coming, you know, after the COVID-19 pandemic, looking ahead to probably what's coming next, and it might be around the corner, that we really seize this opportunity to kind of codify some of what we were talking about, these ethical principles and the frameworks and the mechanisms, because in the end, if we don't talk about it and if we just talk about it and don't find a mechanism to implement it, you know, that's less helpful. So that's a long answer to say, no, it's not ethical, but just to say it's also complex.
Yeah, thank you very much. And definitely it hits at the core point. The pandemic really exposed the huge inequity we have globally already. And clearly we need really a more fundamental solution to ensure really equity and fair distribution of all medical interventions. So everyone really has the right to them and can benefit from them. So now I'll move to Dr. Hiam. So there was a very important concept in infectious disease epidemiology, which is herd immunity. Many heard about it for the first time during the pandemic, but often in very distorted ways. So can you please help us understand what is really this concept and what kind of ethical dilemmas does it introduce?
Yes, the concept of herd immunity is that we need to vaccinate a minimum proportion of the population to stop infection transmission. And if we stop infection transmission, we will protect the whole population. Now, what proportion of people we will need to vaccinate? It really varies from one infection to the other. For example, for measles, we need to vaccinate 95% of the population to stop measles transmission. But for another infection, smallpox, we only need to vaccinate 78% of the population. And this is why it was easier to eradicate smallpox. Now, the ethical dilemma here is that when individuals refuse vaccination and decide not to vaccinate, they are not only increasing their risk of getting the infection, like what happens for a diabetic person who decides not to take the medication. They are actually also exposing others to the infection because they can transmit the infection to others. And they are preventing us from stopping the circulation of this infection in the community. So this has societal consequence that is well beyond the individual. This is why it's really an ethical concern. Because, for example, I can give you another example. We have been having a lot of measles outbreaks just because a fraction of parents decided not to vaccinate their children. And that's why until now, even though we have a very effective vaccine, we are actually not able to eliminate measles. And societies still have to deal with measles outbreak and still suffer from measles outbreak. And for me, this is really an ethical concern that we have an effective intervention, but we're just not able to benefit from it fully at a societal level.
Yeah, thank you very much. So it's, I mean, the dilemma is clearly the actions of very small proportion of individuals are putting the whole society at risk. And this is really a very serious ethical question. Thank you very much for the answer. So now I'll go back to Dr. Abdul Latif. So is it ethical to make vaccination mandatory, given actually what we have heard about herd immunity? Especially for serious infections, which are really put the whole society at risk. Or alternatively, should vaccination always be voluntary? But can we do nudges? I mean, to really put nudges to make people take the vaccine, and maybe these nudges could be serious nudges or less serious. So we'll be very interested to know your perspective. And actually, have you dealt with these specific questions when you were heading the national response and setting this vaccination strategy?
Sure, yes. I'll try to answer by referring to COVID vaccine for most of the part. The four traditional principles of bioethics, which is justice, beneficence, non-maleficence, and autonomy, are all important. However, in times of disasters or pandemics, they run into conflicts with each other. In the process of national vaccination campaign, while paying attention to the autonomy of the individuals, the priority of the principle of beneficence over the principle of autonomy in vaccination should be considered for the wider public benefit in the face of the pandemic of COVID-19. So this is where one maybe bioethical principle should stop and give way for the other more important principle to prevail. Reliable information about vaccines' efficacy and side effects should be made available to the public. And when mandating or strongly recommending a vaccine, like what happened with COVID, to try to stop the misinformation or at least mitigate the misinformation. In the case of, if we take healthcare professionals as an example, where some countries mandated that they get vaccinated. And we know that the pandemic showed how important healthcare professionals were for the continuity of care, so to prevent the healthcare systems from collapsing. And it was very important to maintain the safety and the continuity of care. And, some countries resorted to mandating it, some countries didn't. And we understand both, I think, sides of the equation. So I think countries need and governments need to formulate programs to ensure that the uptake of vaccines by the healthcare practitioners that take place during pandemics. Maybe they have during normal times like now, that they need to take this into consideration more seriously and not wait for the next pandemic to decide how they will manage important vaccines for the healthcare professionals and for other individuals in the community. During the pandemic, each country had to take very difficult decision, and because it was a very difficult time. Healthcare systems were overwhelmed with very sick people or dying patients in the corridors, as we saw on TV in many countries. And we, one would not look in hindsight and blame a country and say this is unethical what you did. I mean, if you were in their situation, you'd probably justify why those reasons were made, because it was for the good of the community and the entire country. A similar dilemma can arise when trying to eradicate serious infections. I mean, for smallpox, like we heard, you probably need 80% of the vaccination of the population to be vaccinated. Even if it takes that much for a future pandemic, would we be able to, to eradicate a new pandemic? Will 80% of the world population take the vaccine? So this becomes, with the growing sentiment against the vaccine and the anti-vax movement that's taking place, this is going to be very hard. And in Qatar, we did not mandate the vaccine. However, in the early phases of the vaccination campaign, the country eased the restrictions on individuals who got the vaccine. So they had more mobility, more freedom. They could go around. They will not be quarantined. When they come back from travel, they will not be quarantined. They can go into restaurants. They can go into malls, and so on. So this was like nudging, like I think the word you used, people to get the vaccine. And we found that the strongest incentive for people to get the vaccine was for them to travel to other countries, because many countries required people to be vaccinated for them to come in. So it was not mandatory. However, if you want to come to our country, you need to be vaccinated. So that was, semi-mandatory. And people, when they returned from travel, if they were vaccinated, they did not have to be quarantined. So that was another incentive, short of mandating the vaccine. And this actually encouraged many people to get the vaccine, even those who were speaking loudly against the vaccine. Whether this was ethical or not, I think it can be, maybe argued both ways. Going forward, I think it will be whether vaccines should be mandatory. I think there will be less and less mandatory, especially with the very strong, again, anti-vax, movement that's taking place. And unfortunately, most of those claims are false claims, and they are leading to death, they are leading to morbidity, they are leading to disability, like the slides you shared with us earlier. We had people here, like in other countries, die because they thought it was a conspiracy, and they didn't want to take the vaccine. And some of them were in the intensive care unit, and they did not, believe that there was such a thing as COVID-19. So I don't know if I gave a good answer for your question.
Yeah, so basically you still would like to keep a principle of autonomy, so vaccination has always to be voluntary. I mean, completely mandating it, you don't seem to agree with that, but you are perfectly fine with nudging people to really try to get the vaccine. Now the question is, to what extent we should nudge people? I mean, really the concern is, and back to just the point about herd immunity, I mean, we already have demonstrated we can eradicate an infection that killed hundreds of millions of people throughout human history, like smallpox, by only increasing vaccine coverage above the herd immunity. Now, we can do this for smallpox, we can do this for polio, but we haven't, because there is always this very small proportion who are standing in our way to making this milestone and moving on with our lives. So I think still maybe the question is open, really to what extent we are going to need the nudge, but I take your point. It's becoming, in fact, harder and harder to make this nudge, because we see stronger headwinds coming from the anti-vax movement. Yeah, but thank you very much for your perspective. So now going back to Dr. Hanan. So let's say I'm a healthy and young person. I am unlikely really to suffer from severe COVID-19 if I get infected. So is it really ethical for me to simply not vaccinate? Because unfortunately, after all, it's my decision. And because for me, as an individual, my personal benefit is definitely not as high as someone else. However, by doing so, I'm exposing others. I can get the infection, I pass it to someone who has comorbidities, and that person could actually die. So in reality, I'm contributing to their death. Is this ethical? Where to draw the line also?
I feel like you're giving me a leading question. So I'm hearing what you just said about, there's always this small group of people that stands in the way. And I perfectly understand that frustration. But the reality is that human beings are complex, and you can give them the best evidence, and they don't necessarily act in the way that you expect them to, or the argument doesn't seem as straightforward to a lot of people as it may seem to us who really believe in the vaccine. So I think, first of all, it's just acknowledging the complexity of the thought process that goes behind this. So, back to the idea of a healthy person, what is their responsibility? They're not going to be personally harmed, but they will, and that's true, they will contribute to the harm, possibly the death of others. I think I'll just take a public health approach to this question, as I do with everything, and say that this all goes back to, again, what public health is all about, which is the tension between, your personal rights, your right to express an opinion that may be unpopular, your right to move around, your right to bodily autonomy, and so on, and of course the public good. And these aren't conversations that should start during an epidemic. This should be a very integral part of our education, and I say this as an educator. And it's also part of our civic engagement and those kinds of discussions. So when you grow up, with the idea that it can't be all about what I want to do and my personal rights, and that there is a measure of responsibility that may actually lead to extreme harm to an individual, it's not going to guarantee that 100% of people will align with that. But I think, you give people time to think about this idea and to discuss it and to debate it and so on. And I think that people aren't, fundamentally evil. They're not trying to be, evil by refusing the vaccine. I think people just get very scared. And they act in a way, they, refer to the default of trying to protect themselves, even if it's going to come at the expense of others. And I think that is very much related to issues of trust, to issues of social cohesion, sense of community and civic engagement, and so on. And those are the kinds of things that you have to build. Someone in the audience was saying there's COVID-19 fatigue, and I agree with you, but I hope that we use this downtime to be addressing really important questions like this, because we have to do it preventively. It's you talked about mandates. I think mandates are very serious business that you can actually avoid. I'm not saying that they can never be applied. I can certainly see situations where at least partial mandates work, but your need for them can be maybe not completely averted, but can be reduced by this amount of education and civic engagement and so on.
Yeah, so really the bottom line is we should not be even at the point of having to answer this difficult question. Yeah.
And actually,
yes.
sorry to interrupt you, but just
Yeah.
to follow up, if you think about, what happened in Qatar, so we didn't have a mandatory lockdown, as far as I know. We didn't.
Correct. Yeah.
But people did not move around, and they adhered to the advice that, we shouldn't be mixing and we shouldn't be going out, at least, in the earlier stages of the pandemic. So we have seen behaviors where, despite the absence of a mandate, people did adhere and did comply.
Yeah, that's correct. Yeah. Great. Thank you very much, Dr. Hanan. So now we'll go back to Dr. Hiyam. So different vaccines can introduce different ethical dilemmas. Now let's go even to a different vaccine here, to like HPV vaccine, which is a vaccine against human papillomavirus, which is a sexually transmitted infection, and the infection that causes basically all cases of cervical cancer among women. So what kind of ethical dilemmas does a vaccine like this introduce? What's your perspective? Thank you.
Yes, thank you for the question. Let me just start by stating that cervical cancer is actually the second most common cancer among women. And now finally, after years of research, we have a vaccine that is 99% effective. So the vaccine reduces the chance of a woman getting cervical cancer by 99%. However, uptake of this vaccine has been low. Several governments and parents have been very hesitant to give the vaccine to their daughter out of concern that this might give the impression that they are open for promiscuous sexual activity during teenage years, or that the vaccine, by getting the vaccine, they are allowing early engagement in sexual activity. Although there has been in the literature no evidence that an increased uptake of the vaccine will actually affect sexual activity in teenage years among girls. So the ethical concern here is that we have an intervention that is very effective, that can wipe cervical cancer, that can save a lot of hardships for women by not going through surgery or chemotherapy or radiation or even risking their lives. But there is this cultural fear that are preventing us from really benefiting from this vaccine. And in my opinion, this is really a missed opportunity.
Yeah, thank you very much. So this is an interesting example where it's just simply some kind of cultural fears, that has been actually preventing government, from parents, from protecting their own actually daughters, which is really unfounded. But it shows really how complex sometimes these ethical dilemmas can be, Okay, so thank you for your perspective. I will go now back to Dr. Abdul Latif. And it's an issue actually already mentioned, but it would be good to discuss it further, which is the issue of adverse effects. We have seen that vaccines do have adverse effects, but these are usually mild and treatable and very rarely serious. But they are there. So how should we do really in terms of conveying the information about these adverse effects? Now, one could think, okay, and this as you mentioned, your point was we should actually communicate transparently to everyone the risks of these adverse events. But unfortunately, the way people think are binary. The moment they hear that there is an adverse effect, immediately they think that the vaccine is bad. So by doing so, we introduce another ethical issue, which is we are spreading in reality misinformation unwittingly, reducing uptake of vaccine and so on. So maybe we should downplay them, or not communicate the information necessarily immediately or later, or how to deal with a complex like this. The problem with vaccines is that they are so well studied, we know their adverse effects. Everything else has an adverse effects, but they are not necessarily studied or well documented. So how to deal with such a dilemma?
Yes, thank you for the question. From our experience, the best way to fight misleading information that's spreading through social media, particularly and in the community, is to communicate to the public in a very open and transparent way the side effects, mild, moderate, and severe, and their incidence, and repeatedly so, because they may not stick from the first time. The public, particularly the young people in the community, may listen with suspicion and doubts when they hear this information from healthcare professionals, wearing a jacket and a tie and appearing on TV. But they are more likely to believe it if it comes from a peer or a community member who will be saying the same information, which is true information, whether using the social media or going on TV and saying, I got the vaccine, my family got the vaccine, we are all fine, we didn't really suffer any of the, side effects that you've been hearing about. And we did deploy this. We tried to do that in Qatar to reach out to the public, using members of the community to help the Ministry of Health convey information. We also did not rely on the vaccine side effects that comes with in the package insert or with what was published in research or by the FDA. We actually conducted our own surveillance or survey post-vaccination, where we had the primary healthcare system was calling every patient receiving the vaccine, every individual, at least 2 times over a period of 4 weeks, to survey them for side effects. And they had a checklist of side effects, and they went over them one by one. And the public also had the opportunity to go on the website and record or report the side effects that they are suffering, or they felt after the vaccine. And we shared this information with the public, with the community, and we were very open and transparent about it. And after vaccinating thousands of individuals, we did not really find any serious side effects. We had a few cases of pericarditis in young people who presented to our system, but I don't think we even exceeded 20 in total for the entire country, and all of them recovered. We did not have any serious adverse outcome. And if you look, at the huge registries like the post-marketing adverse vaccine-associated adverse events, like in the US and UK and Europe, they are all very reassuring. So I think the best way is to clearly, communicate the side effects to the public, but couple that with messages that catching the virus itself is much worse than any potential side effects from the vaccine.
Did you feel that by communicating the adverse effects, actually people became hesitant about vaccination?
No, I think with repeatedly saying the messages, but doing it in using different means, and particularly using community members to communicate this information, I think we softened the position of many people who are hesitant to get the vaccine.
Okay, so really we continue with the principle of transparency in terms of reporting adverse effects, which is really essential as an ethical principle. So now going back to Dr. Hanan, parental consent for minors. So vaccinating children, particularly when parents refuse consent, presents ethical challenges regarding the child's best interest, parental rights and public health considerations, and so on. So ethically, where we should really draw the line, and we see this a lot, as you are aware, with measles vaccination as an example. Yeah.
So first of all, as a disclaimer, I'm not a bioethicist, so I don't know if I'm qualified to completely speak to, the line and legal consequences and so on when it comes to parental consent and minors and so on. Certainly, there is a threshold. There is a threshold of harm that might require intervention. Because ultimately what you want is the benefit of the child, and in case of an infectious disease, you might also be talking about the benefit of persons, other than just the child. So, but what I was just thinking is that in our region, we don't hear very much about these cases where, the parents and the state end up in court because the hospital or the state feel that they want to intervene and the parents are not letting them, or something of that nature. It's not within our culture, and I only speak, about our region because that's what I know. to us, the relationship between parent and child and decisions about a child's welfare are very much in the private domain. They are very much considered the purview of the family. So I think it would be difficult for us to implement a mechanism or a strategy that involves the intervention by the state into this private issue. And that takes me back again to what would be a better approach, and that is the engagement with the parents and the education and so on. I mean, I'm a parent, and I think all of us in this panel, at least, we're parents, and we all want the benefit for our children. We don't want to put our children in danger. So it's very much about communication and about trust, and hopefully not getting to a point where there would have to be legal interventions.
Yeah, so it's really, again, back to the concept of where we are failing is in averting the question to begin with. If there was really real engagement, from early on to prevent some things like this actually from happening,
Sure.
which is very, very serious. I mean, now we are seeing it big time, actually. Especially after COVID-19 vaccination, people are not getting their basic vaccinations.
Yeah. I mean, we had the problem before with the MMR because of, the link that people make with autism and so on. And now it's even more difficult. And in truth, there will always be a group of people that no matter how intensively you engage with them, whether in the West, we see, for example, certain religious sects or groups that will refuse vaccination on religious grounds or so on. So there will always be that group, but at least from a public health perspective, the smaller that group is, the less at risk you're putting, herd immunity levels. So.
Great, thank you. Yeah, so back to Dr. Hiam, and this relates to COVID-19 vaccines and specifically mRNA technology. Was it really ethical for us to use a new technology all of a sudden, develop vaccines using it, and then vaccinate millions, hundreds of millions of people with it within very short time? Does this actually introduce an ethical consideration of making such sharp decision that affects so much people very quickly?
Okay. I would argue that really there is no ethical dilemma here. I think there is more a misunderstanding. mRNA technology is really not new. It has been around for over 3 decades, and it has been very well researched. It just happened that during COVID-19 pandemic, it was the perfect opportunity to actually use mRNA technology to develop effective COVID-19 vaccines. But this technology is revolutionary, and it's being considered beyond COVID-19 vaccination. So right now, for example, if we have cancer patients, instead of having to go for these patients with non-specific treatments, having them to go through chemotherapy and radiation with uncertain outcomes, we can actually now design an injection that can target specifically these tumor cells and make sure that we improve the survival for these patients. Also, this technology is being considered for other therapeutics, for example, like diabetes and cholesterol, where a person can have like an injection that will regulate his cholesterol levels, reducing the side effects from daily pills, improving adherence, so improving the overall health of the person. And I would argue that the ethical concern is that shall we really prevent the use of innovative, revolutionary biomedical interventions that can really have a major impact on the betterment of society, just on the ground of skepticism?
Yeah, thank you very much. So it's definitely an interesting question in the sense of, new technology may bring some ethical considerations, but often we forget that these ethical considerations are actually hindrance to bigger ethical considerations. If we have a new technology that can increase access to interventions in a global scale and makes it even more equal and better the life of a lot of people, sometimes get actually missed. So this seems to be I guess an example where to that. Yeah.
Yes, and I would
Thank-
add, like any new technology takes years and even decades of very hard research, because before we are able to have like a technology that can be implemented effectively in biomedical interventions.
Yeah, indeed. Yeah. Thank you very much. So now going back to Dr. Abdul Latif. So do we have an ethical responsibility to compensate individuals who experience side effects from vaccines? I mean, we have just seen really people vaccinate not only to protect themselves, but also to protect society. So if they get an adverse effect, should we actually be responsible for these adverse effects?
Yes, thank you. COVID-19, I'll revert back to COVID-19 vaccine, saved millions of lives over the last 3+ years. I think an estimate that in 2022 alone, that there were around 19.5 million lives that were saved just by the vaccine. So this is huge. When a person is vaccinated, they not only protect themselves, but chances are that they'll protect their family and maybe other members of the community, particularly those who are more vulnerable to the disease. And the benefits of the vaccination, as was mentioned earlier, significantly outweigh any risk that may happen. The overwhelming majority, the hundreds of millions of people and maybe the billions of people who were vaccinated, for most of them, the side effects were only mild or moderate. However, we must acknowledge that a small proportion of those people will end up with more serious adverse effects or vaccine-related injuries. And we must keep in mind that not all serious ailments that happen after receiving a vaccine is due to the vaccine, particularly COVID-19 vaccine, because people started blaming the vaccine for all kinds of things, strokes, road traffic accidents, you name it, things that don't make any sense. So individuals who got vaccinated, who elected to take the vaccine, or who were pushed to take the vaccine one way or another, put themselves at a very small risk of injury following vaccination. This injury may be permanent in rare situations. And this is for the benefit of the community. So therefore, we must acknowledge that in the very rare cases where there is an injury that's permanent as a result of the vaccine, then those people deserve compensation. And this acts like a social contract in the community and between the community and the government. And this also actually helps reduce the need for litigations. Many countries have national vaccine injury compensation programs, including the US, the UK, many European countries, Australia, even COVAX. But I don't think, or I don't believe that we have one in our region that I'm aware of. These programs do not require injured persons because of the vaccine to prove negligence or fault by the healthcare provider or by the vaccine manufacturer or anyone else to get compensated. And the purpose of this is to remove the need for accessing compensation for vaccine-related harms through litigation, where the process can be lengthy, can be complicated, and hard to prove in a court. So under such programs, governments compensate individuals harmed by the vaccine with the intention of removing the need for litigation. Vaccinating a whole population to save lives can and will lead to a small number of people getting harmed at the end, and compensating people who get this kind of injury is, I think, justified and is ethical, and governments should be proactive. And I think this may improve the compliance of the population in future pandemics if they know that there are systems that will compensate them should injury happens.
Yeah, so it's a very clear answer. These people should be compensated. It's really society's responsibility to those people, because it's not really an intervention that they're taking for themselves only, but it's also for everyone else. Thank you, Dr. Abdul Latif. So now, Dr. Hanan, sorry, it's another difficult question. Okay. Okay, it's about actually misinformation. We have seen so much misinformation during the COVID-19 vaccines, and it turned out after investigation, some of this information was spread for commercial interest, people who wanted to sell alternative therapies, or sometimes because of political interest and so on. And this information caused lots of problems and really resulted, in fact, in people, dying, as simple as that. I mean, we had actually cases where simply, actually, children prevented their parents, elderly persons, from taking the vaccines because of this misinformation, and actually they died when they got COVID-19. So should we deal with those people who, I'm not talking here about a question of whether they are entitled to freedom of expression and so on. I'm talking about people who we can actually demonstrate they were spreading information for commercial interest, for example. Should we actually have some form of punishments? After all, if somebody drink and drive, we punish them because they are putting risk to society. Should we do the same with these people?
Well, the cost of asking a difficult question is you don't get a yes or no answer. And so I think definitely at some level, regulatory interventions are needed. And they've been shown time and again in public health to be very effective. So, on one hand, you have the health education and the awareness raising and working on the individual. But then we all know, for example, from seatbelts or, from traffic laws, that laws work and regulation works. We know that from tobacco taxes as well, for example. So is there room for, any regulatory action? I think yes, but let me say that it's going to be very, very difficult. One is exactly for the point that you made, which is intent. So there was misinformation and there was disinformation. So in some cases, people simply didn't know any better, and they were just amplifying through social media incorrect messages and information and inaccurate information without the intent of maliciousness. And then there are cases of disinformation where clearly there was a political agenda. In some cases, there were commercial gains to be made in other cases, and so on. So in reality, distinguishing, intent, misinformation from disinformation is hard. As you said, a lot of it is done online. So where is the jurisdiction and who has it, right, to impose those sanctions or whatever regulatory actions we make? That becomes very difficult. I'm not saying impossible. I'm saying definitely should be looked into. But then what else can we be doing in the meantime? And, this is really interesting that you've asked me this after the question of compensation. What happens is that a lot of times people who at least spread misinformation, let's not say people who have political agendas, if you look into them, they're not really anti-vaxxers. They either might be vaccine hesitant, or they're people who had a bad experience with healthcare or with social care systems or with the government and so on, right? So rebuilding that trust and showing that there is a social contract and that there, that I think goes a long way towards dealing with misinformation and disinformation and so on. And, I know that it's difficult because a lot of the research shows that people don't go to official website. They spend literally seconds on, the web pages of the WHO or the Ministry of Public Health, or that's not where the information is to be had. And so, again, back to our role as educators, we might have learned about health communication and spreading messages in more traditional classical ways that are not that effective anymore. So what are we teaching our students now about about spreading the message, about communicating with audiences and with engagement and so on? I think that's really important to be thinking about. Again, measures that we need to be taking in addition to many others.
Great. Thank you very much, Dr. Hanan. So I think now it's time to open the discussion for the audience. So if you have any questions, I don't know if you have, yeah, please. Yeah, the mic.
Thank you so much for fantastic discussions. I have one question about more, global perspective and vaccine equity. I see Qatar as a wealthy country in the region, and do you think that people that have responsibility in healthcare system, do you think is there any moral responsibility for such countries to help other countries in the region or outside the region in such public health emergencies? And is this any experience on this kind of help or coverage? And I would be keen to understand how you look at this commitment. If there is a commitment, it's a important, significant commitment, or it's only, in your opinion, a supererogatory act? Thank you.
Thank you very much. Excellent question. Maybe I think Dr. Abdul Latif. So do you see actually a responsibility for Qatar here as a wealthy country, one of the largest per capita incomes in the world, to contribute to addressing this equity actually that we actually have seen? It could be through an international fund for vaccination in a case of an emergency that will come and ensure really equitable access. Thank you.
Yes, and this is brings up a very important point, because we saw the global solidarity really fall apart when it was, when vaccines became available and everybody was racing to buy them, and they were buying, some countries were buying much more than they needed, where other parts of the world did not receive the vaccine for maybe months or maybe even longer. And this is likely to happen again if we go through another pandemic like this one. The fact, which like Dr. Laith said earlier, it's the pandemic uncovered many problems, deficiencies, and weaknesses in the healthcare systems, either at country level or at the global level. And the international health regulations fell apart, where countries agreed before that they will have unified approaches, when it comes to travel and, restriction or not restricting travel and so on in facing epidemics and pandemics. And this is, I think, part of the human nature that, countries behave like individuals, like, I have priority, I manufacture the vaccine in my country or in my region, then I need to protect my population first. And if government didn't do that, they will not be voted, they'll be voted out next election cycle. So we saw politics, having a very strong presence when it came to rationing and of the vaccine and looking at approaching the problem in a global sense rather than an individual, selfish manner. But as a country, Qatar contributed significantly to the COVAX, which was the main, source of vaccine for low and middle income countries. The country contributed very early on. It also contributed to the purchase or procurement of vaccines through the Qatar Fund. So they helped our country helped other countries in securing some of their vaccines. But keeping in mind that the vaccines around that time was scarce and was not widely available. In addition, Qatar offered some of the surplus vaccines that we had to other countries. But at that time, there were many countries trying to donate also vaccines to other countries, and there were not many takers, especially with the issue of storage of those vaccines, which require like minus 70 degrees centigrade to be stored. Not many countries had that facility, and even if they had it at the capital level, they could not offer it at the provincial level. So it was a challenge.
Thank you very much, Dr. Abdul Latif. Yeah, Dr. Ahmed, please.
Thanks very much for a very interesting panel and discussion. I have a question for Dr. Hiam and then a question for Dr. Hanan or one of the speakers. Dr. Hiam, you mentioned in your presentation that the vaccine was quite effective after 3 doses in preventing severe disease, more than 90%. What's your comparison group? Is it people who did not receive the vaccine or people who received 2 doses, 1 dose? So this is my first question.
Yes. No, we actually compared people who received 3 doses to people who received 2 doses. So compared to people who received 2 doses, people who received 3 doses were 75% less likely to have an infection that will develop into severe COVID-19 or fatal COVID-19.
Yeah, so this is in addition also to the comparison of 2 doses to unvaccinated.
Yes.
Yeah, so basically you saw strong protective effects whenever you compare to unvaccinated or for a booster relative to those who get only 2 doses. Is this correct? Yeah.
Yes.
Okay,
So
great.
whenever every additional dose provided more protection than the baseline.
Great. Thank you.
Thank you. My
Yeah.
second question, please, if you allow me, Dr. Laith.
Yes, yeah.
It's about risk perception and risk assessment of the population. We have had decades of tobacco control policies and tobacco control programs failing like hell. People have been seeing these things on the box which says tobacco kills, and these, bad images of people having incredible diseases, but they still smoke. The same has happened actually with the vaccines for COVID. So what would the panel think about risk assessment and risk perception? Thank you.
Yeah, maybe Dr. Hanan. Yeah, so thank you.
Well, thank you for the question. And it is a challenge. It's a challenge, especially for young, healthy people, to get them to think about, long-term complications and so on. So I think part of, and I'm glad you raised this question, because I think part of what we need to be doing in between all of these pandemic cycles or whatever the next health emergency is, or even for business as usual, is health literacy. And that includes the assessment of risk and understanding it. There were so many important messages during the pandemic that got lost simply because of the noise. So for example, the message that you mentioned, Dr. Abdul Latif, that yes, the vaccine comes with side effects, just like, any intervention comes with side effects. But the risk of that compared to the risk of getting COVID, is absolutely a lot less. So I think educating about interpreting risk and messaging that clearly is very important.
Yeah, thank you. Yeah, I think excellent question, because it's really at the core of why we have a lot of, in fact, debates, that there isn't really a truly good scientific understanding of actually risk. Whereas as epidemiologists or public health specialists, we always balance the risk, and this is why we make that actually policy. But unfortunately, communicating this to the public has been very, very challenging, and for the public also to appreciate it. Yeah, thank you. Yeah, please.
Assalamu alaikum. Tashfeen Ahmad from Aga Khan University, Karachi. Just a couple of points regarding the discussion we've just had. Regarding parental authority, there's a talk on parental authority by one of my colleagues, Mustafa Aslam, on Thursday morning. What he generally has told me is that parents have an authority, but they do not have legal rights over the children, what they can do or do not. It's a bit of a complex issue. Perhaps those who are interested can attend that Thursday morning, 9 o'clock session by Mustafa Aslam. Regarding Qatar's contributions, it's not just about vaccine. Pakistan is an LMIC with like 250 million people. We had severe shortage of resources, and Qatar had been very helpful at that time. Vaccine supplies, medical aid, equipment, many other things Qatar had provided. We appreciate Qatar's support for that. You might be wondering why I'm so interested in this topic. I'm an orthopedic surgeon by background. My wife happens to be an ID specialist, Nausheen Nasrin. She was the first physician in Pakistan who admitted the first COVID patient who came from Iran. So I've been closely following while in the lockdown at home how she has been managing the COVID patients. Now, my question was regarding the prioritization of vaccination and other things like ventilators. Especially when it comes to healthcare workers, it probably made sense that healthcare workers got the priority for vaccination because they're the frontline people who get exposed. But in terms of ventilators, our purpose, the physician's purpose, is to save lives of the public. So can they be prioritized for ventilators? And that would essentially imply that the public's right is being prioritized to their own rights to live. So that's an ethical debate. I was wondering if you would have a solution
just to make sure I understand, so your point is prioritizing ventilators to whom?
To the healthcare workers.
Okay. I don't know if there is, maybe Dr. Adalat here.
Here in Qatar, fortunately, we didn't have that issue. We didn't face like shortages in ventilators. The government worked very quickly in securing more ventilators. And we actually expanded our MICU beds significantly. We had like 500, 600 MICU beds within a short period of time. We dedicated the whole hospital, one of our hospitals, to become an ICU hospital. And we had many people on ventilator at the same time, but fortunately we didn't have to make that choice. Who should we give the ventilator to? Like, unlike what happened in some, even European countries where they were short on ventilators and they had to make a decision who should live and who should die. So we did not have that problem. And although many of our healthcare workers fell sick to the virus, only a small percentage of them ended up in the ICU. And we did not face that shortage. So I can't speak from our own experience. But when, if you ask that theoretical or, ethical question, if you had two people, one healthcare worker and one lay person from the public, and they have equal risk of deterioration and death, who would you prioritize the ventilator to? I don't know, as healthcare workers, you are tasked to save the public, the patients, but also the healthcare worker now has become your patient. So what I'll try to do is to try to get another ventilator from somewhere else.
Yeah, great. Thank you. Yeah, please. Thank you.
Yes, you can hear me. Got a loud voice, but thank you so much. It was great panel discussion. So my question is ask about the HPV vaccine. So there is also an element of mistrust as far as industry is concerned with the HPV vaccine, because it does have a bit of a bad legacy in terms of how they conducted their initial clinical trials in LMICs and how non-transparent the adverse events were. There's a big cover-up, by the company in terms of certain methodologies that were used for recruiting young patients, especially young girls, for these trials. So there is that issue of trust, because I think it takes a long time for us to develop that trust with the public, and it takes one issue to completely bring you back to ground, to zero again. But in terms of setting a national agenda of health, in Pakistan, we now have HPV vaccination as one of the top 10 things that we need to address in Pakistan. Now, given that there are other pressing infectious diseases, right? So how do we navigate that? How do we navigate that choice? It's not, for me, for HPV vaccination, very effective, because again, HPV is not a single dose vaccine. It's like a 3-course vaccine, similar to HPV. But we've got a huge push now to advocate the HPV as opposed to, because nobody's giving us a free HPV vaccine. But we've got, you know, a big push because there's a lot of, again, there's a lot of funding for this. So how do we navigate choices like that?
Yeah, so basically the question is how to prioritize among vaccines in a country with limited resources, limited budgets. They cannot. And actually we have had, I mean, I can tell you, I mean, just recently we had this discussion with Egypt regarding HPV vaccination. They want it, but they have a huge population. I mean, it's a decision that has serious financial consequences. Yeah. So maybe Dr. Ham, your perspective.
Yes. So, I mean, it's definitely a difficult choice, but I think every country should have like a list of priorities of what diseases are the most prevalent, what diseases make the largest burden in terms of healthcare cost, and which infections have the most consequences. Not only on in terms of like how many people eventually get the infection or develop sequela, but also like what resources are available. Do we have the resources to tackle this? So prevalence could be a decision. Another decision could be whether really saving like how important it is to like address, for example, a specific segment of the population where we can have the major improvement in terms of quality of life. So, for example, if I can save few mothers from, you know, dying from cervical cancer, how much impact would this have on their quality of life, on the quality of life of their families, compared to other infections that may be, for example, more prevalent, but they are more manageable on the long run? It's a difficult decision, but I think things have to be weighed. Now, we have been recently in a conference, and we've had a discussion with a colleague, and for HPV vaccines, it seems that there is now new development that maybe a fraction of the dose of the vaccine can be enough actually to stimulate an immune response against cervical cancer. So this could be good news and could, you know, mitigate some of the issues of this.
Yeah, I mean, one vaccination now can be actually distributed over many doses. So to vaccinate more people, reducing the cost. Yeah, thank you. Any further questions? Yeah, looks like we are set. Actually, let me just make sure online. I don't have anything. Yeah, I think we are set. Yeah. So thank you. I would like just to thank the panelists for really an excellent, rich discussion. Thank you very much. And thank you very much for the audience for contributing and to this discussion and for your attendance. Yeah, have a lovely afternoon, and I hope you are enjoying Doha.
Thank you so much. It was a great discussion. Refusing to be